Hello, everyone. Welcome to the meeting today. We're going to talk about delirium and other stuff. So, Dr. Aman and the other team members will present, and we'll take it from on. So, Dr. Aman, when you are ready, you can go ahead with your team.
Yes, sure, Dr. Nadir. Hello, Dr. Sobia. You can go ahead now if you are ready.
Yeah, sure. Hello, everyone. Good afternoon. So today, me and Dr. Hajer will be presenting the topic delirium. So, change slide. So today we will be covering what is delirium, how to recognize and diagnose it, the predisposing and precipitating factors, how to evaluate and treat delirium, and the interventions to prevent it. We'll cover the topics incidence and morbidity, recognition and diagnosis, its neuropathophysiology and predisposing and precipitating factors, evaluation, management, and prevention as well. So delirium is a term which is interchangeably used with all these terms. Following other terms: acute confusional state, acute mental status change, altered mental status, organic brain syndrome, sometimes with reversible dementia, and with toxic or metabolic encephalopathy. So you will be amazed to know that incidence is quite high in older patients, and it's 1/3 of older patients presenting to emergency department, as well as 1/3 of the patients which are already in general medical units having age 70 or more are also more likely delirious on admission itself. So we see that there is a 10-fold increased risk of death in hospitalized patients, whereas a 3 to 5-fold increased risk in nosocomial complications, prolonged stay, and post-acute nursing home placement. It also increased the risk of death for up to 2 years following discharge, and it also increases poor long-term outcomes and poor functional recovery. So when we see, it's not easy to recognize delirium, and that is why only 20% of cases are recognized by physicians, and only less than 50% of cases are recognized and documented by nurses. So when you recognize delirium, it's better to have somebody from the family or somebody known to that patient, so that any change in consciousness or any unusual things happening to that patient should be documented by that family member who is constantly with that patient to see the difference in the consciousness or any cognition changes. So to diagnose delirium, we have DSM-4 criteria, as well as CAM, which is also called confusion assessment method. So DSM criteria is precise, but it's difficult to apply. And confusion assessment method is more clinically useful, and its sensitivity and specificity is also high, which is greater than 95%. So in DSM-4 criteria, we have somebody having disturbance of consciousness with reduced ability to focus, sustain, or even shift in attention. If there is any change in cognition, like having memory deficits, disorientation, or language disturbances, or a perceptual disturbance, which is not better explained by any existing dementia in that patient. Also, it's very necessary to diagnose delirium that its course has been very short time, like hours to days, and it has a fluctuating course, like it fluctuates with the passage of time. The cognition level fluctuates within day and with night, and there should be evidence from history, physical examination or labs that the disturbance is a direct physiological consequence of a medical condition or a drug. So coming to confusion assessment method, you have 4 criteria, and you require features 1 and 2 and either 3 or 4 to label somebody having delirium. So the criteria are acute change in mental status and fluctuating course, and inattention. These 2 are necessary, whereas point 3, which is disorganized thinking, and point 4, which is altered level of consciousness, you can have one of these and then you can label a person is delirious. So the spectrum of delirium, the most cases we see are of hypoactive delirium, in which a patient is sluggish or very less active, and it although it is greater than 50% of cases, but it's less recognized and also have a poor prognosis. Whereas the one which is hyperactive or agitated delirium, in this spectrum we have less number of cases, but it's easier to recognize because you can see a change in you can easily recognize somebody having aggravation or agitated delirium. And also we can have a spectrum which in which a patient can have both the kind of delirium, like some of the times the patient would be having a hyperactive nature, and sometimes it would be the patient would be having a hypoactive nature. So moving forward, when we see neuropathophysiology of delirium, it's not actually well understood till date, but the main causes which we see are cholinergic deficiency. We all know that acetylcholine is an important neurotransmitter for cognitive process, and any change, like even the decrease or increase in such a neurotransmitter, can cause delirium. And even drugs which can like anticholinergic drugs and its overdose can cause delirium. So to reverse such overdose, we have drugs like phytostigmine. Delirium is also associated with increase in serum anticholinergic activity. So anybody having drugs on anticholinergic drugs can develop delirium, because this is a precipitating factor. We should also not forget about inflammation, because when we say that we see that in inflammation we have an increase in C-reactive protein and interleukins and tumor necrosis factor. All these can break down the blood-brain barrier and allow the toxic medications to have an access to the cranial nervous system. So these can also induce delirium. Also, the post-operative patients having cancer or infections can have delirium, because all these scenarios in all these scenarios, the patient would be having an ongoing inflammation in the body and will have increase in all these inflammatory markers, which are C-reactive protein and interleukins and tumor necrosis factor. When we talk about delirium, it's actually a sum of predisposing factors and precipitating factors, and it goes in hand to hand. Like when a patient have already have a lot of predisposing factors, you won't need a lot of precipitating factors to cause delirium. So the more the predisposing factors, you need the lesser precipitating factors to cause delirium. Now we are seeing the predisposing factors. So it includes advanced age, somebody having already dementia, functional impairment in activities of daily livings, any medical comorbidities, history of alcohol abuse, even the male gender, and sensory impairment like decreased vision or decreased hearing. And that is why when we assess the patient, so we also inquire in history that if patient has decreased hearing or decreased vision, so we want to make sure that you first correct those impairments, like you give the patient with appropriate working hearing aid or appropriate spectacles, so that the predisposing factors can be minimized. Now the precipitating factors. So acute cardiac events, any acute pulmonary events, even the prolonged bed rest can induce delirium. Any drug withdrawals like having sedatives or having an alcohol abuse history, even fecal impaction, fluid or electrolyte disturbances, indwelling devices, also infections, medications, its overdose, restraints, severe anemia, uncontrolled pain and urinary retention can also induce delirium. So when we see the incidence of delirium in post-operative patients, we see that the elective non-cardiac surgeries has the lesser incidence, that is 15%, and the cardiac surgeries and hip fracture repair has a higher incidence, that is 50%. So we see here that the incidence of post-operative delirium increases as the number of pre-operative risk factors present in the patient. So a person having no pre-operative risk factors will have a very less degree risk of incidence of having delirium post-operatively, that is 2%. And if we see that a patient having 1 or 2 pre-operative risk factors will have a risk of having incidence of 10%. And if a patient has 3 or more preoperative risk factors, that patient would have an increased risk of 50% incidence of delirium. And what would be these preoperative risk factors? So these include age 70 and older, cognitive impairment, any physical functional impairments, history of alcohol abuse, abnormal serum chemistries like electrolyte disturbances, and even the intrathoracic and aortic aneurysm surgery. So anybody having 3 or more preoperative risk factors will be at high risk of developing delirium postoperatively. So it is seen that mostly delirium onset is on the second day of second post-operative day, and it's usually associated with post-operative pain, post-operative anemia, and use of certain drugs like benzodiazepines and opioids. So it is recommended that you adequately make the patient pain-free by providing adequate analgesia, limit the patient's sedation, and avoid all those precipitating factors like making sure that the patient is not on any medication overdose, or if a medication is not needed, so don't like over drug the patient with unnecessary medications. So yeah, these recommendations, if we follow these recommendations, we can prevent post-operative delirium. So further slides would be delivered by Dr. Hajer. So over to you, Dr. Hajer.
Yeah, thank you. Thank you so much, Dr. Sobia. Hello, everyone. I will continue with the evaluation of delirium. So once the diagnosis of delirium is established using confusion assessment method, which is known as CAM, we will start initial evaluation by thorough history and physical examination. In the history, we have to focus on time course and cognitive change and associated and other symptoms like pain, dehydration, urinary retention, history of trauma, and we have to review the medication, either over-the-counter medication or prescribed, and if there is substance abuse like alcohol. On physical examination, check for vital signs, oxygen saturation, general medical evaluation, and neurological mental status of the patient. Okay, abnormal finding in history or examination will guide us for further evaluation and lab testing, including complete blood count, electrolyte, renal function, urine analysis, liver function, drug level, ABG, and chest X-ray, ECG, and culture. We do not do a cerebral imaging routinely. It is rarely helpful, except if there is a history of head trauma or new focal neurological finding. Same as EEG and cerebrospinal fluid. We do that, we do only if there is seizure activity or signs of meningitis. Okay, we have once we know the underlying cause of delirium, now we go for general for management. Management include the general principle. Delirium require interdisciplinary effort by doctors, nurses, and family members. It is multifactorial approach is the most successful because of multiple factors contribute to delirium, as we see. Failure to diagnose delirium and manage it is will lead to costly, life-threatening complication and loss of function. Okay, what is the effective management for delirium? We have to identify and treat the reversible contributors, maintain behavioral control, anticipate and prevent complications, and restore function. Identify the reversible contributors by the medication optimization, as we will see, treat the infections and pain and fluid, all of that, maintain behavioral control. We have behavioral and pharmacological intervention, and anticipate and prevent complication before it happen, before delirium occur. So the best way is to prevent it before it happen. Okay, this is a list of medication that can precipitate delirium. So whenever possible, we have to reduce the dose or stop the medication. The most common one is anticholinergic medication, opioid, and benzodiazepine, one of them. Yeah. Others are antidepressant and antihistamine. All of them contain anticholinergic activity. Okay, we have how to manage behavioral problems in delirium. We have to provide social restraints. We know that it is better to familiar people like relative and friend are the best resource to provide the patient with personal interaction and constant observation. In case there is no relative, we can, if there is no relative available, professional sitter can observe and provide personal interaction with the patient and observe him. So we have to avoid physical and pharmacological restraints. If absolutely necessary, we can use haloperidol. This in case of severe agitation, for example. Okay, we can use, we said in severe agitation, we can use haloperidol. In mild delirium, 0.25 to 0.5 milligram orally can be taken, or we can give increase the dose for IV or IM. And in severe delirium, we can go for 0.5 to 2 milligram, and additional dosing every hour as required. The most important thing is to assess for akathisia and extrapyramidal side effect. Avoid older people with Parkinson because of extrapyramidal side effect. And we have to monitor for QT interval prolongation, torsades de Pointes, neuroleptic malignant syndrome, and withdrawal dyskinesias. Rehabilitation use orienting stimuli like clock, calendar, and radio. Provide adequate socialization. Use eyeglasses and hearing aids appropriately. Mobilize the patient as soon as possible. Ensure adequate intake of nutrition and fluid by hand feeding if necessary. We can help the patient by hand feeding him. Educate and support the patient and family. Yeah. Okay, the best management is prevention. The best management of delirium is to prevent it before it happens. We have an intervention called HELP. It stands for Hospital Elder Life Program. It is a program for delirium prevention. currently being disseminated to hospital. It uses interdisciplinary staff and targeted intervention protocol to improve patient outcome and provide cost-effective care. Focus on non-pharmacological approach. Yeah, like for example, for sleep deprivation, they have sleep protocol involving warm milk, back rubs, soothing music. They avoid psychoactive and other high-risk medications. In a summary, delirium is common and associated with substantial morbidity for older patients. Delirium can be diagnosed with high sensitivity and specificity using the CAM, confusion assessment method. A thorough history, physical, and focus labs will lead to underlying cause of delirium. Careful medication review is mandatory. Discontinue any likely to contribute to delirium if possible. Managing delirium involves treating the primary disease, avoiding complications, managing behavioral problems, providing rehabilitation. Again, the best treatment for delirium is prevention. Okay, this is the end of our topic. We have some questions. Okay, a 72-year-old man is evaluated because nurses are concerned about his agitation, which is increased markedly in the evenings. He underwent emergency hip replacement 3 days ago after he fell and fractured his rib. He requires antipsychotic agent to control his agitation at night. He yells, "Help me," constantly, and is determined to get out of bed alone and walk. In the year before his fall, he had stopped working and driving. The reasons are unclear. The patient's history includes hypertension, benign prostatic hyperplasia, osteoarthritis. There is no history of dementia. On examination, he appears confused and disoriented to place and time. He has some pain with hip movements. Neurological findings are non-focal. Which of the following is the most helpful in establishing the diagnosis of delirium? Order electrolyte, blood urea nitrogen glucose, and thyrotropin. Determine why the patient stopped working and driving. Perform the digit span memory test. Order CT of the brain. Review the patient's medication list. Most helpful in establishment the diagnosis of delirium. Any answer? How to establish the diagnosis?
So I don't see any answers in the chat.
Go. So we said that for delirium, we have to establish the diagnosis first. There is answer E. Review the medication list. Yeah, so most of the answer is E. Yeah, for delirium, we have to establish the diagnosis first, then look for the underlying cause. So here, to establish the diagnosis, we perform the digit span memory test, which is a part of CAM, confusion assessment. We have to establish the diagnosis by CAM, confusion assessment method, first, then look for the underlying cause, which may be medication or lab or anything else. Thank you, everybody. Okay, the second case, 89-year-old man is admitted to a nursing home for rehabilitation after being hospitalized for pneumonia. He is anxious and fidgety. He is widowed and lives in the community. History include hypertension, benign prostatic hyperplasia, major depressive disorder, and chronic back pain. Medication on transfer to the nursing home include metoprolol, oxybutynin, paroxetine, acetaminophen with codeine, and amitriptyline. This is a list of medication. Which of the following medication is least likely to contribute to delirium? Amitriptyline, acetaminophen with codeine, oxybutynin, paroxetine, or metoprolol. Least likely. Yes, thank you, Dr. Sarah. Yes, Amal, you can go. Yeah, it's metoprolol. So, yes, most of them have anticholinergic activity. All of them have anticholinergic activity. So metoprolol is safe for them. The last case, a 90-year-old man is brought to the emergency department by his family because he has had an abrupt change in behavior. The patient moved into his daughter and son-in-law's house a few months ago because he was no longer able to manage living alone. A few days ago, he became aggressive, angry, and he hit his son-in-law for no apparent reason. He has also become incontinent in the last few days. He has multiple bruises, which the family suspect are from falling. The patient's history include moderate dementia and benign prostatic hyperplasia. Blood pressure is 160/90. All other vital signs are normal. The physical examination is unremarkable. He is demanding to be released from prison and is aggressive with the staff. He is uncooperative with the neurological exam, but he appears to be moving all extremities well. Which of the following is the most appropriate next step? Bladder scan, lumbar puncture, electroencephalopathy, CT of the brain, basic metabolic panel, CBC, and pulse oximetry. Okay, thank you for the input, Dr. Sarah and Dr. Taib. Yeah, the answer is basic metabolic panel, CBC, and pulse oximetry. This is the fairest thing we do to know the underlying cause of delirium. The patient have no neurological finding, or we use lumbar puncture only in case of there is meningitis, signs of meningitis, or yeah, but he is well. Neurological examination is well. Thank you. Thank you, everyone. Anyone have any question?
Hello, thank you so much. Can you hear me?
Yes.
Yeah.
Thank you so much, both Sobia and Hajer, for great presentation. This is excellent brief presentation about the delirium. And it's an important topic when you go to the hospital. Hopefully soon, every one of you guys, medical graduates, to get into residency. So I remember when I was on the floor first rotation, I had this patient. She was delirious. She was confused as soon as I entered the hospital in the morning. And my senior was so calm, and I'm like, how can we help this lady? So he mentioned that about delirium, and we checked all the lab as mentioned in the last case, and the oxygen level, and so as far as assessing the patient, managing the underlying cause, hopefully soon we'll see a better result. So it's a big topic, but it's an important one. Thanks for a great presentation. I'm gonna extend the topic a little bit more. During my second year, third year, we have patients in the ICU also with some delirium. So we talked a lot, and when I went to the fellowship, it's one of the major topics in geriatrics. So I'm gonna just share the screen with you guys. Okay, let's share the whole screen. So if you look at delirium, for example, the scale or the CAM scale, you will have a lot of information. One of them is MedCalc. And if you go to MedCalc, for example, CAM, confusion assessment method in the ICU is developed by Dr. Sharon. In a way, she, I think she was a nurse at one point, but she developed the whole thing about the CAM method. In this version, they use RAS. But before we jump into this, if we go to the Wikipedia about just the confusion assessment method, they will give you a background, as mentioned by Hajer and Sobia, and the basics about the elements of the score and interpretation. But what I'm referring to here is how they adapted the first version and then modified it to make a different type of CAM. So we have the first version, let's say a short confusion assessment method. It has 4-question assessment. The scoring, depending on what's present and not present. So there is a way, and here's available languages for the CAM short. It's available in Arabic and other languages, Spanish and Turkish and so forth. Then there is a long one, which has 10 questions. And also the interpretation will be different, but it's also listed in different languages. There is CAM-S, stand for severity. So it's also a different one form, and the other form is the long one with a severity as well. So if you go back to the math calculation, the calculator, we go to RAS, and this is a method where it's just about the agitation sedation scale. So we want to see how bad is the patient as far as description. Usually at the hospital, the nursing staff or the senior, the nurse aide, will tell you, hey, the patient last night was comparative, or they pulled the IV, or so you will give some point to each of these symptoms or description of what happened. If the patient, let's say, is totally sedated and arousable, is one thing, but if the patient is combative, it's on the other side. So it's kind of two different ends. One will be very agitated, aggressive, and the other one is calm, sedated. And then there are some symptoms in between. And this might be variable. So at one point you go to see the patient, they may be with it, able to answer you. You come a couple of hours later, they may be agitated, pulling their IV lines and Foley catheter and so forth. So these symptoms may change over time, ups and downs. But you cannot just score according to what you see. Let's say the nurse told me the patient was agitated, less stress, and I give 2 points for agitation and restlessness. And I copy this result, I add it to the, so if it's more than 3, I will say yes, or equal 3. Then it will assess, yeah, the patient is acute onset, it's fluctuating, it's different from their baseline. At home, they were fine. So I will say, yes, it's different from their home. Patient fluctuating mental status in the past 24 hours, it's an acute, yes, something like that. So it will give you the results here. If the attention test, so you're gonna administer an inattention test, can the patient follow these letters? For example, can you ask the patient to say C, they say C, something like that. If they can, yes. If they have a problem, then you say yes. Is the patient up and down? Yes, something like that. So you will have the end result, and then it will give you what the management, if there is, and what action can be done. So this is a tool or method that can be used in the ICU, or the modified one or the other short one can be used at the floor level, for example, or in nursing homes, for example. So you will have the most important part is the description of what exactly happening. If the staff tells you the patient was all over the place, using foul languages, punching, something like out of character for that patient, then you want to get the details and assess like the diagnosis. So let's say his acute mental state changes because of the delirium. Then the next step is to investigate why, what happened. Is it the medication? So this is a severity score. You can add them the same way, the short score or the long score. And short one is range 0 to 7, a long one is 0 to 19. So you find the patient is delirious, you have the diagnosis, then you go over the list of the possibilities that what can cause this patient to be delirious. Sometimes the patient might have surgery, just came out of the surgery, then they may get confused, especially older patient. In my case, I had a fracture and I went to surgery. When I came out, the anesthesia still in. I was talking to my family about the smell of some type of food, and that food is kind of back home. We use it a lot, so my memory went there. So it's not in the hospital by all means, but for me, my brain was sensing that smell. So for all the patients may have some sensation, they may hear things, voices, or may see people or may interact with the environment differently as far as input to them, voices, TV sounds, or other patients talking. For them might be confusing as far as their condition because of the anesthesia still in their system, or pain if they are in pain, or if we give them pain medication, it may cause some confusion. So you want to identify which one or more causes for that patient, as mentioned in this presentation before me. So you want to address what's the possibility, what's the causes, and identify, and then try to fix. Medication is the easiest one. You review all the medication and remove, or if possible, change the medication that can cause delirium. So it's a method for the CAM form. It's used in different universities. Here they use it, I think, in New York, in other places. So it's very useful tool. This is a video about the CAM method. It's a brief one. I'm gonna show you the. Hopefully you can hear the sound looking play and see. Can you hear that?
No.
Okay, so you couldn't hear the sound, is that correct?
Yes, no worries.
All right. So what I'm gonna do, I'm gonna share the link with you guys. Maybe you can. I'm not sure if you can play it in your devices while we still in the meeting. So I'm gonna just go over you can watch that later. I'm gonna just forward this video as slides for you. So you have the negative outcomes and you have confusion with dementia. This is a big topic as well. Sometimes it's hard to differentiate. Is it delirium? Is it dementia? Is it underlying dementia? Now it's appearing as delirium. So in this case, the patient with the wife giving history for the doctor. So the doctor will assess the patient. At this time, the patient is not agitated, but from history, maybe the wife will tell you what's going on. So if the patient has some disoriented as far as who's this lady, or what the time now, or something. So they may have disorientation, or they may talk about some other topics, 2 different or 3 different topics. So it's called organized thinking, something like that. They may not be attentive to what you are talking about. They may look at the ceiling or look at somewhere that their attention is not there. So
Sorry to interrupt.
Yes, go ahead.
Also, I saw this video earlier, and when you look for inattention, so you actually call out a list of letters. There's a specific letters, and then you ask the patient to squeeze your hand whenever you hear that letter A. So whenever you call out those letters and whenever the letter A comes, the patient would squeeze your hand. And in case if the patient doesn't squeeze or squeeze on in place of another letters, like in place of A, then you would count as positives, like positive that the patient is inattentive. And then that would lead to give you a more score. And then you can diagnose with the delirium. So that would help in diagnosing inattention.
Excellent, excellent. Thank you so much, for Sophia.
You're welcome.
So yeah, so there is some ways that medical provider can assess delirium and attention and inattention. So this is the positive or negative result depending on acute onset, fluctuation, inattention, disorganized thinking, and then the altered level of consciousness. So these are the main criteria for diagnosing delirium using the CAN method. I just want to share with you guys. Hopefully this will help you when you start your residency, when you treat patients. So any questions for Sophia or any other comments for Hajer or Sophia? Or did you have any experience in your practice when you see patient, not necessarily here, but in other countries where you practice? If no, we can move on. So the next topic I want to share with you guys is AI GPT in classes. So this is going on. We talked about it in the last few days and weeks, meetings, but at Harvard University, they were talking about whether or not teachers will use it as a tool, because it's becoming more and more like the norm to search, like Google search, but now we are using the AI or chatGPT. This is one of the tools that can be used in classes. So some of the educators were against that, because the reason behind the resistance is that they say it's not going to help the student. It's another way of cheating. So if we give them an assignment, they will use the AI. The result will be there. Just they will copy paste it back to us, and there is no way for us to identify like the result is verified. Is it the work of the student or work of the artificial intelligence machine learning kind of approach? So here's an article that came 2 days ago. So they were talking about artificial intelligence as a newest wave of generative AI tools. One of them is chatGPT. So it's rapidly adopted by many people, including students, and some of the educators as well. So it can help in many fields. Education is one of them. So the obvious problem will be cheating. How can you minimize this in education level or in classes? We also talk about focusing on the problems distract us from the opportunities AI can provide. Anyways, the educators are on both sides of the aisle. One Some of them agree it's a good tool. The students or the learners can use it to help them learn more and educate themselves. And then there are other people who says, no, let's stop, make it a big problem. And what they say also is that the artificial intelligence is a great tool, but it can bring you some results that are false data or made up, for example, citation, or totally incorrect information. So the problem is AI is, it will look at all the internet available data online and summarize some of them. So if there are misinformation there, it can bring some of this into your results. In one instance, I saw one video, it made up some citation. For example, we asked the artificial intelligence to write abstract with some references. So the references, it was made up the author and the journal. We looked at the author, there is no name with that name of the author, and there is no journal with that. So could be made up. And when we asked the artificial intelligence, it says, yeah, this is an incorrect information. So it seems like incorrect information. So it can recognize that there is no, there is a problem with the citation they made, but it's still, and the incorrect information could be there. So in English, they say garbage in, garbage out. This is could be a big problem with using artificial intelligence. So how can we overcome this? So one of the things that they offer is that they make sure the students must have enough knowledge, at least basic or some knowledge about the topic they want to examine more to produce sufficient results. So when they get the results out, they can verify, oh, this information is a good information or is misinformation, and then look at the references. Is this good, valid references, or they are invalid references? So it can be used, but at least we need the students to have some knowledge about the topic that they want to research. So how do we do that? We need to train our students to properly use the technology by interactively interact with the AI. So the results will be meaningful, but interesting, as well as valid or accurate, as much as we can get that. It's like telemedicine. It's going to be used, but some people may use it in a wrong way. So you want to minimize any risk. One objective of this talk is to integrate AI into the classroom. It's going to happen sooner or later. So it's better to understand how it can be used successfully. And as I mentioned, just to minimize the risk. The educators in all institutions must craft some policy for classes. So if I'm developing a class, I need to think about incorporating or integrating this artificial intelligence or less machine learning approach, so that the student can use it, but I have to use some limitations for the students to guide them how to use it. For example, at Harvard, educators created an AI policy for undergraduate and MBA students. And they found that it's really appreciated, and more or less expectations are met. So you assign something or projects, you want to put some limitation or guidelines for the students to adhere to that policy. How did they do that? So it should include some of this consideration. Under what circumstances that AI or artificial intelligence is used, permitted, or is not used or forbidden. How they cite, again, you want to get a credit or a legit references. You don't want to get information from a website that's not legit or distribute misinformation. Deceptive data, as we mentioned, you want to avoid something like that. You want to focus on ethics and responsibility. So students, you want to educate them about using this tool in that direction. And then they mention in this article some examples of this policy. For example, you can tell your student, I expect you to use it in class. In fact, some of us will be required it to be used. Learning to use is an emergent skill, and I provide tutorials. So I'm going to show you this and this and this videos to how to use it or when to use it. And then you can say, I'm happy to meet and help you with any of these tools during office hours, something like that. This is an example of one of the policy, for example. Again, we should be aware of the limitation of the artificial intelligence in this. One is ChatGPT. If you provide minimum effort prompts, you will get low quality results. So when you ask, it's like chatting, you ask a specific question, the more detail in the question you give, the more refined data, accurate data you will get. If it's not limited, it's going to be not useful, for example. Again, don't trust anything coming from it. It's a tool that you want to verify what it gives as a result. Not everything is a fact when it comes to, so you have to check it or double check. So for example, you can tell them, I want you to identify the paragraph that you are using. If it's inappropriate, then tell them how to use it. So it's a totally different new approach or new way of teaching, and for the student, new way of learning. So still educators are trying to figure out what the best way to use it for helping the student or the learners. There is no right or wrong way, as far as we know so far, how to apply that. So it's just, we want to help the students elevate their learning curve. Again, hello?
Yeah.
Yes, Mr. Nadi, we hear you.
Okay, sorry, my app is kind of disconnected and came back. So back to, So it's a useful tool for educators and for students. And in this program, I think we should try to integrate this into our curriculum so that you can make use out of it. But at the same time, I want to raise some points that you use it with some cautious, verify whatever data it comes out, verify the references, and then you can use it to help you learn more about certain topics. Any questions about this topic? Or any comments? Anyone of you use this tool, ChatGPT? So we're going to use it in the near future. Let me know how we can improve the learning experience for you and for these coming new applicants. Hopefully soon they will join. All right, we can move on to the next topic, or any updates as far as your projects, guys. I know it's a match week. Hopefully we will hear good news, but any updates as far as new ideas, new abstracts, presentations? I'd like to share with you that Dr. Amal and her team finished developing the app INR, and it was uploaded to the store. So maybe we can share that. So we have, okay. I can share with you here. This is a website, Google Play. The app is called INR Guard. I'm going to share you the video as well. Hello. The link will be here, so you cannot be using that link. I'm gonna just, why don't you try it now if you have the Android phone? If you don't have the Android phone, we can use the other phone. I think we have it in Glide app. Maybe the Amal, can you share the Glide app version? Maybe the people with iPhone, they can look at it.
Yes, sure, Dr. Nader.
And maybe we can discuss about the features and so forth. Oh,
I have thing my side. Yes.
can I just silence myself for a second?
ده طويل.
The last part I want to share with you is in the past we wrote a grant for this program that was 2 or 3 years ago. This is a draft for that proposal. We were talking about why we need more staff or more workforce in geriatric medicine, and how about the number of graduates, medical graduates who don't match about 8,000 or more. What can be improve their applications so that they can know more about geriatric medicine, and how can we do that during the pandemic? We developed a telemedicine approach, which is tele-research fellowship. So at that time we started with 5 unmatched medical graduates as a proposal, and we increased the number the first year to 16. It's based at MSU, and some of the staff members here helped establish this fellowship. And at the time, our hypothesis was that unmatched medical graduates can help geriatric population. We can help them integrate into the system and to this as their future. We expect graduates to be ready even before they start their clinical training, training to COVID and beyond. So we have specific aim at the time, and then we put a hypothesis or theoretical rationale behind that. And for each proposal, we need to put a timeline for the project. So we started with the IRB approval in July, and then we started recruiting and students, and then we start with some basic research tools, identify target of research projects, some ideas, and then for each idea or project, if needed IRB approval, we will get that approved, and then we start collecting data. Next step will be data analysis, and the final steps will be how we can finalize and publish all this data. And we were successful by June of 2020. So within 1 year, we were very successful. At that time, we got some support. So the budget was for development of software that need some licenses be paid for the student to use them, and some travel expenses for the student to participate in some of the conferences. Some of them were just registration, so the presentation will be online, and we collected a good amount of money for the first year, and we applied again the second year, and we got more or less similar funding. So it was funded for 2 years. The third year, we tried to approach different out of the MSU kind of funding, but we were not successful. I couldn't complete the application on time, and for this grant option, also we were out of the window. So I'm trying to repeat the same for this year. So I'm gonna write or rewrite the same approach, but now we will focus on workforce in general, because now we have not only the medical graduates, but we have some dental graduates, some therapy, and we want to include some other specialties like nursing, maybe nursing graduates or nursing students, social worker, or students of graduates. So it's kind of a team approach. As in geriatric, we look at patients, more or less we look at the patient collectively from a team approach. So the nursing will put their team, their input, the SINA or the therapist or the pharmacist. So all this we want to include in our pool of learners. So we will try to write the same proposal, but with the focus on the interdisciplinary approach using workforces in geriatric medicine. We don't limit ourselves to the geriatric medicine, as some of you might be interested in other subspecialties, pediatric or neuro or psych or other, but it's kind of a base for you to start, and then you can divide or you can go your interest, the track of choice that can be of benefit for you. So this is a work that we are working on currently. Hopefully soon we will finish the proposal for this year and submit it for funding. If we are successful, we will let you know. Hopefully we can cover some of the cost. I know some of you presented in the past in some of the conferences in person, so some of you paid for registration or hotel or travel expenses. So hopefully we can cover some of the expenses in the future. So any questions or any comments from the group here? So I see that Dr. Amal shared her link for the app as well for people who use iPhone. So if you can download the app, look at it, and maybe add some comments. We need to have some numbers in the website where it's it will list how many downloaded the app, and if there are positive feedback or reviews, it will help us tremendously. So hopefully in the coming weeks, Dr. Amal also and her team can present how they develop this app. Any other comments or questions from the people here?
Assalamu alaikum, Dr. Nadir.
Alaikum salam wa rahmatullah. Dr. Arich, go ahead.
Yeah, I got accepted as a fellow, nephrology fellow at Harlem Hospital.
Excellent.
So I'm also apply for the match. So if I get match, can I able to withdraw from this position, or?
When you talk to them, what did they offer you? When you accepted the ID, the position as fellow, what
2 days.
did
When? 2 days ago.
2 days ago, did you sign any paperwork or not yet?
Yes, I signed.
So it's kind of balancing. What do you think is the match your chances? Did you have good interviews or?
No, yeah, I got two interviews, but one it's pre-match, and the other one is categorical. I think I have my chances low, so
Yeah, so if I were you, if I think that way, I will stick with the ID fellowship. If
it's
you think
nephrology. It's nephrology fellowship.
a nephrology fellowship, okay. I thought it's an ID. Yeah, so I'll stick with fellowship unless you find out that you matched. And then you can just contact them again and excuse yourself and mention that it wasn't expected and so forth.
Okay.
But in that case, I would see in this group if there is anyone interested in nephrology as a fellowship, if they didn't match. So at least for the program, the nephrology fellowship, you did not cause major harm because they invested in you. I assume they had an interview time with you and paperwork with you. So I don't want you to let them look at this as waste of time and money. So if you bring them some replacement for the position, maybe they can have a better chance of finding a good fellow for their program. Because at the end of the day, they want someone to do the job for them.
Yes.
You or someone else. Exactly.
Exactly.
Yeah.
Thank you, Dr. Nader.
You're welcome and congratulations.
Thank you.
And keep me posted, please. Thank you. Anyone else wants to share? So for the dental group, dental graduates, any one of you present here, can we talk about topics that your group might be interested in presenting in the coming weeks? If no,
hello.
Okay. Hello. Yes.
Hey.
Hey, Manham. Dr. Manham, go ahead.
Yeah. I think one of the topics that I mentioned before, the COVID tongue. So we would like to read more about this topic and maybe present it one day, if that's okay with you.
Oh, sure. Yeah. So if you let me know what's the topic, what days you and your team will be available, we'll put it in the schedule.
Yeah. Yeah, I will provide the list of topics. So I will discuss this with my team, and I will email you the list of like other topics that we can present it for the upcoming sessions.
Excellent. That would be great. Thank you so much.
Thank you.
You're welcome. And this goes also for Meher. You are with us. So
yes, Dr. Nader. Hello.
Hello. Yes. So if you let me know when you will be available, what topic you will be presenting, I can add it to the schedule.
I have a couple of topics in mind. I can present certainly. Either it can be like in 2 to 3 weeks. I'm okay with that. I don't know about next week, but I'm not available on the week of 24th, 25th. So either I can do either next week or 2 weeks after. I have like 2 or 3 topics in mind, I can send you a list, and please let me know.
Sure. Sounds good. So let's
Okay.
work on scheduling that. That would be great.
All right. Thank you, Dr. Nadir.
No problem. Thanks. I know also we have some pharmacy with us in the group, so I hope that we can also touch base on some of the topics regarding pharmacy. It's a big topic like polypharmacy and all the others, but we can subdivide that into certain medications that we need to have an idea about the limitations or how we can use them with success in all the others. Riham, are you with us?
Sorry, did you say Rayyan?
So sorry, no, I mentioned Riham, but maybe she stepped out for a minute or two. But all right, any other topics that you discussed?
Yes,
Oh,
sir.
Riham, go
Here.
ahead.
Yes, sir. You were saying? I was just feeding the kids. Sorry.
Oh, sure, no problem. So I was talking about some of the pharmacy topics that we can discuss in the near future. If you have anything in mind.
Not at the top of my head, but I can think about it. Something with the group that we were just talking about, talking to.
Yeah, anything in geriatric, in pharmacy, or
Okay.
pharmacy or medications. Yeah.
Okay. I'll think of something and share with you. Is that okay?
That's okay. Yeah.
Okay. Thank you
If you
so
have
much.
time, yeah, you're welcome. Yeah. If you have time, yeah.
Absolutely. Thank you.
No problem. Thanks. So in the coming few weeks, we're gonna finalize acceptance for the new class. So we will introduce them to you guys, and then we'll divide into teams, and hopefully we will have more projects that we will work on. Again, if you have any ideas or suggestions, let me know. I know this coming week and maybe the week after will be the match and the SOP week. So I know some of you might be very hectic or busy. So let me know how can I help, if anywhere. Wishing you all the best, and let me know. Anything else you want to add, any of you, before we adjourn this meeting? I know Dr. Nafisa, she's not present today, but she will be presenting one of our abstracts, I think, in the coming few weeks in one of the conferences, and I think some other abstracts will be presented as well, at least at AMDA, which is good. So we will be working on establishing a website for the fellowship. If you have any ideas or any comments or anything that you want us to focus on the app, on the website, that might be beneficial for the readers or anyone who browses the website, please let me know. Any ideas as well as comments about the program for improvement for this program also, please let me know. All right, I want to thank Dr. Amal and all the presenters from today's Sobia. Thank you so much, and Hajer, thank you so much for great presentation. Thank you all the attendants for today's meeting. I wish you all the best, guys, and we'll see you next week. So Ryan is going to present at the AAN, the neurology, in April. So that's good. Let me know if I can be of help. I think you are finishing the poster. If you let me know if you need help. Thank you. Or just go over it with you. Fine. In the past, what we did is we offered time during the meeting so that the fellows will be able to present and get some feedback from the group. So let's say Ryan is going to present our poster in April. So maybe in 2 weeks, she will present to this group and we'll give her feedback as far as what can be improved, what questions she may be able to get ready to answer. Something like that. It's just a proposal. All right. Thank you, everyone. Have a wonderful day. Good luck for everyone. Thank you. Bye-bye. Assalamu alaikum.
Thank you so much, Dr. Nader.
Thank you.
Thank you so
Thank
much.
you, Hina. Thank you.
Thank you so much, Dr. Nader.
You're welcome. Thank you. Have a good day.
Thank you, Dr. Nader.
Thank you, Dr. Nader. Yes.
Thank you, Dr. Nader. Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.
Thank you, Dr. Nader.
Thank you. Rahmatullah.
Thank you.
Thank you.
Dr. Nader, I do have a quick question, if you don't mind.
Yes, go ahead.
For the AAM, there is a fee that we have to pay towards presenting. One of my fellow colleagues, I wrote a letter to one of her managers. We're looking to get a grant from them. I'm still waiting on approval from that. But I was just wondering, I recall you back in January talking about potential grants or scholarships for the fellowship. Is there anything like that that can help support or help offset some of the costs related to presentations for this fellowship? Or
Yeah, in the past we had some support, but as I mentioned during this presentation, I'm going to apply for the MSU grant, and we'll see if they accept that. It will be available. Is it for this April presentation conference?
So we have until March 30th to pay off the amount. So I'm not sure if your grant will come in time for that or not, but if not, then
yeah.
Go ahead,
Let me know the cost for the registration and the travel, or it's going to be online or virtual presentation.
It has to be in person. They sent me an email saying all presentation is in person. I don't mind in regards to like the cost for like hotels and travel. I'll cover that myself. But I'll send you an email regarding the costs and everything then, inshallah. Thank you so much, Dr. Nader.
You're welcome. If you send me, that would be very beneficial for me, and we'll try to cover as much as we can. Yeah.
I really appreciate that. Thank you, Dr. Nader. And my team has been very supportive, but I know like with the match system, it's already like, it puts a strain on us financially, but I appreciate your help. Inshallah, I'll send you an email today and we'll connect. Thanks again.
Sure. Thank you so much.
I really appreciate it. Okay. Have a great rest of your weekend, Marcelo.
Thank you. I really appreciate it. Wish you good luck.
Thank you. Thank you so much. Ma'as-salama, Dr. Nader.
Okay, everyone. Assalamu alaikum.